Welcome, everyone. It's our 20th session, I think, of our COVID-19 community of practice for Ontario family doctors, and this gathering place has never been more relevant. So we're delighted to have a great panelist today. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine. And I'm delighted that we're able to co-host these sessions together with the Ontario College of Family Physicians. And I'm going to turn it over to their president, Dr. Liz Muggah, for a bit of an introduction.
So good morning, everyone. Yes, pleasure to be here with all of you this morning. Lots of news, of course, about COVID, so feels good to be connecting with all of you from across the province as we digest this news. We have a great panelist today, as always, and they'll be introducing themselves in just a moment, and this is an accredited session. Next slide. I'll just read the land acknowledgement. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. I'll hand back to you, Tara.
Yeah, and I just wanted to share a reflection from actually this month's Toronto Life, where my colleague, Dr. Suzanne Schusch, was featured and talking about this incredible logistics of vaccinating Indigenous populations in remote communities. And she talks quite a lot about vaccine distrust and building vaccine confidence, which is really going to be top of mind of what we're going to talk about today. She says, I used to make the mistake of going over the top when treating vaccines. Then I would notice that moms didn't come back for their appointments and I was losing patients. Indigenous people face everyday racism and discrimination, and it can wear on you to the point of skepticism and mistrust. Now, when my patients are not ready, I accept it, and I share information on risks, benefits, and alternatives. I want patients to have the information from someone they trust. I thought that was just so poignant and really, I think relevant to the discussion we're going to be having today. Next slide. So of course, we've designed this community of practice as a place to come together, and we've got many relevant sessions that we're actually going to shout out to during this session because of everything that's going on. So you can find these past sessions at the website there that Nina has also posted into the chat. These past sessions are now actually also accredited, so if you didn't attend them in person, you can still get main pro credits if you listen to them later on. Next slide. Just a shout out to our planning team, and we always are welcoming topics for the next round, so please do put those into your evaluations at the end. Next slide. So today I'm delighted to have our panelists who are going to just introduce themselves one by one. I'm going to start next slide with Dr. Onye Nnorom, who's new to our community of practice. Onye?
Hi,
go to the next slide, Brian.
Hi, good morning. So my name is, as you said, Dr. Onye Nnorom. I am a family physician and public health and preventive medicine specialist. I work in a couple of places at U of T, but I'm the Equity, Diversity, and Inclusion Lead for the Department of Family and Community Medicine, the Black Health Theme Lead for the Faculty of Medicine, and the Associate Program Director for the residency program in public health and preventive medicine that trains medical officers of health. My clinical work is at CAMH. And as far as my relationships, just grants and research supports, mainly in 2020 for PCORI at CAMH, and also honoraria for a talk that I'll mention later that I gave at the Ontario College of Family Physicians.
David?
Thanks. I'm David Kaplan. I'm a family doctor in Toronto, and I'm the Chief of Clinical Quality at Ontario Health, where I receive employment income, and I receive a stipend to do these sessions with the Ontario College of Family Physicians. Good morning.
Daniel?
Hi, good morning, everybody. Daniel Warshafsky. I'm a public health physician in the Office of the Chief Medical Officer of Health, and I have nothing to declare.
Next slide. Liz?
Yep, I'm Liz Muggah, family doc in Ottawa, and I have a stipend that I receive for my role with the Ontario College of Family Physicians.
And I'm Dr. Tara Kiran, and I've listed some of the sources of salary supported research grants there, but the only one from a for-profit company is from Gilead Sciences for a grant to cure Hep C. Next slide. And we're of course delighted to be joined by all of you, many of you from the GTA, but also from well outside the GTA, and you can see some of that diversity of geography here on the slide. Next slide. We do use your questions to inform our discussion, and just a reminder that you can put those in. We prefer you to put the questions into the Q&A box. The chat is wonderful for you to share resources and connect with other people, provide your opinion on things. But if you have questions, please put them in the Q&A. And because we have hundreds of our participants on this call, I really prioritize the questions that get the most thumbs up. So if you see another question there that you like, I think the most effective thing is to put a thumbs up, and that will then get it to the top. Our panelists are also great at answering questions by typing. So, as you get onto the Q&A, just please do look at the answered sections before you post your own question, because there's a chance that your question will already have been answered. Next slide. So we of course got a few different topics to talk about today. We've got COVID raging in the province, and we're going to talk a little bit more about our responsibility when it comes to that. We also know that we want to be delivering more vaccines, and that's been a struggle for reasons that are still not clear to me. But we're going to talk more about where we're at with primary care vaccine pilots and what some of the next steps are that we might be hearing about. And then we're going to start, though, by really diving deep into the issue of vaccine confidence in the Black community. We know that COVID has hit our Black communities hard here in Canada, in Ontario. There's lots of data about that, very specifically in Toronto. We know people in Toronto who are Black are much more likely to get COVID-19. We know that racialized communities where many Black people live are, though, at the same time, much less likely to get the vaccine. And so this is something that we need to address, and as family doctors, we can address. And so we want to start just by doing a little poll to understand kind of where you are at with things before we turn it over to Onye. So Brian, could you launch the poll for me, please? We want to get a sense from you how confident you are in addressing vaccine confidence among the Black population. It should say, how confident are you in addressing vaccine confidence among the Black community? And 1 is not at all confident, and 7 is very confident. So it's how confident are you in addressing vaccine confidence among the Black community? So you've got about 30 seconds to answer that. How confident are you in addressing vaccine confidence among the Black community? 1, not at all confident, and 7, very confident. And you can choose anything in between. I'm just going to repeat the question one more time because it's wrong, I think, on the poll. How confident are you in addressing vaccine confidence among the Black community? So Brian, do we have some results to share? Okay. So we can see that there's a moderate level of confidence. I think there's quite a few people who are saying, they're not really feeling very confident. I think there's about 30% who are, rated 6 or 7 that, they're pretty confident. And then we've got in the middle here, I think the majority of people between 3 to 5 saying that they're, somewhat confident, but that, that they probably are going to be looking forward to hearing more from Onye around how we can do better. So with that, Brian, I'm going to turn it over to Onye Nnorom, and Onye and Brian, maybe you can go to her first slide.
Okay, so thank you, Tara. And I just kind of want to do a little bit of level setting of expectations around this talk. So I'm very happy to be here, but this is a bit of a primer. I'm only speaking for about 10 to 12 minutes, which doesn't really do the topic justice. So at the end, I'm going to collect information so that there'll be a part 2 where we do come back as Black community leaders. That might not be me to speak about this, because in fact, Black people have been here in Canada for centuries, and our health needs have largely gone unattended, and the issues that we face have not really been recognized in medicine, and they contribute to the issue of confidence. So I do appreciate that Tara has understood that. So please understand that this is part one, and I'm hoping to give a primer and then come back, or a member of my team come back to do a deeper dive. But simply to say, so for Canada's Black population, we are the third largest, quote unquote, visible minority group, which is a problematic term, but it's Statistics Canada term, after South Asian and Chinese here in Canada. In Toronto, we're about 8% of Torontonians, in Ontario, about 4.5%. We do not self-identify as African Americans, no more so than Indigenous people would self-identify as Native Americans, or you would identify as being American, unless you are in fact American. But what sets us apart from the other quote unquote visible minority groups is that a huge proportion of our population is actually Canadian born. So yes, about a little over half of us are are immigrants from particularly East Africa, a bit of West Africa, and largely parts of the Caribbean. So that's what we have here, is what's kind of demonstrated as Black communities, but 43% of us, like myself, are Canadian born, and even 8.9% are third generation or more, some the descendants of people who were kept in bondage and became slaves here in Canada. Next slide. So very important to be able, I wanted to kind of be able to provide some level setting when it comes to race-based data and COVID-19. So Black people in particular have been, according to Statistics Canada, 4 more likely to succumb to the virus than members of other groups. So that's from Stats Can, where race-based data has been available. And it's not due to biological differences between white and Black people or other groups, because there are no biological races. It's a social construct, but it is because of social factors, right? So being more likely to be in situations where we are essential workers, not being in positions where people can self-isolate or have sick days, living in multi-generational homes, and then also just the stress of everyday racism, making people more likely to have chronic diseases like hypertension and diabetes, which make the virus certainly more, as we say, makes the virus more attracted to you. Communities, according to Statistics Canada, with racialized women, so it is gendered, have higher COVID-19 death rates than communities with predominantly white women. Again, thinking about essential workers. And according to the report from the Public Health Agency of Canada, because I know this question came up in advance, vaccine hesitancy is highest amongst the Black population. And that's where they looked at different populations, including Indigenous. But for the COVID-19 vaccine, the hesitance is highest. So only 34% of Black Canadians stated at the end of last year they would be willing to take the COVID-19 vaccine. So that is older data. I think that what we've seen in the United States and in the UK, which had similar low numbers, is that vaccine confidence has increased, but it is still low compared to other groups. And the reason for that is actually a matter of distrust. So in most Black communities, you do not see a high level of overall vaccine hesitancy, which is more in the literature is where somebody doesn't believe in vaccines. What you see is that where it's a new vaccine or considered experimental or something like that, there's a lack of confidence. And a lot of that traces back to us being used as guinea pigs in research, but also having distrust with the system, which is very much anchored in a legacy of anti-Black racism. Next slide. So what is anti-Black racism? So this is definition from the Ontario Anti-Racism Directorate, and it really is about the unique subtype of racism that people of African descent experience. And that's really related to our unique history and experience of enslavement. So because we had the transatlantic slave trade in North America, including Canada, stereotypes were used, or myths, actually not even stereotypes, lies and myths were used to uphold the transatlantic slave trade, so that Black people were less intelligent, were subhuman, needed to be closely monitored, and had a different pain threshold. And we see that still play out in the biases. So that's one of the pictures on the right, the biases that play out in society today, so that it's entrenched in our Canadian institutions, policies, and practices, and kind of manifested in the legacy of the social, economic, and political marginalization of African Canadians in everyday society, and has been flagged by the United Nations as a major issue with regards to the human rights condition of Black Canadians. Next slide. So I'm not going to go through this in detail. I gave a talk through the Ontario College of Family Physicians at the conference on Black health, but simply to say where race-based data has been collected in Canada, our everyday experiences, and I use kind of experiences from institutions linked to the social determinants of health, have been impacted by systemic racism. So it's not just, I know people think it's about history and Tuskegee, which was in the United States, but most people actually don't know about, even within Black communities, lay people don't know about the Tuskegee experiment. What we know is what's been passed on in our everyday experiences of being treated like second-class citizens. So you can kind of go, we can kind of run through this, but I won't be going through this in detail. Can you click? It's almost like clicking next slide because this is animated. Please just run through it. Thank you. But overall, our lived experience in Canada is quite different than the white Canadian experience. And because of the issue of anti-Black racism and that stereotype that actually we're less intelligent or not to be trusted leads to, the over-policing of us in society, stereotypes, and all types of things that happen to us in the foster care system, the education system, the correctional institutions and police system, employment, and income that go beyond just the issue of immigration. So even when you control for education and you control for immigration, you do see for the Black population in particular different than other visible minority groups who have come as immigrants, that our outcomes are worse. Next slide. And so how does that play out in primary care? So I'm watching my time. How does that play out in real life for you, right? And so where we have this legacy of anti-Black racism that we experience in primary care, it really leads to kind of two areas where you can have distrust. And that can have an impact even as you decide to talk to your patients about the COVID-19 vaccine. So you might have your own implicit biases. We know those exist in medicine. So where there are assumptions or microaggressions, like the young Black male who might come with a hoodie and you don't realize he's an accountant or a medical student, then you might get that breaches the patient physician, the therapeutic alliance. And so you can have patient resistance to follow up, lack of treatment, or not following your care, or not trusting your advice that the vaccine is safe. The other is just lack of awareness by yourselves as providers. So for myself, having worked in Black community, sometimes where you might just have a lack of understanding of a Black patient's journey and challenges, that can lead to invalidation of their experiences, denial or minimization of their experience. And again, that might happen when you decide to kind of talk to your patient about the COVID-19 vaccine. If they're talking about, well, I don't trust government or I don't trust hospitals, it's where you minimize that experience and a patient not feeling safe to share information that impacts their health and well-being. So that distrust for providers in the system becomes reinforced. Next slide. And this, I won't have time to go over, but just to say that it exists as lateral violence in medicine. So I'm the president of Black Physicians Association of Ontario, and we surveyed physicians, and Black physicians also experience a lot of anti-Black racism. So when you're thinking about, I got questions about PSWs, when you're thinking about people who are either your peers or who are in the hierarchy of medicine positioned with even less power, the amount, next slide, of anti-Black racism, microaggressions, so just everyday slights and insults and feeling othered and excluded. This is what Black physicians reported, let alone how PSWs and nurses who are of African descent experience in our healthcare system. Next slide. So I just want to quickly let you know, so for the Black Physicians Association of Ontario, we exist really to increase the number of Black physicians in Ontario, but also to advocate for improved health equity for Black Ontarians. And when it comes to the vaccine, we have a Black Health and Vaccine Initiative. Next slide. I'm at 10 minutes, but I'll just take 1 or 2 more minutes. So I already spoke to our mission and vision. Next slide. So really, this is to let you know that our initiative, which will fully launch next week or over this weekend, is to advocate, educate, and vaccinate. And so we are advocating for Black communities to be prioritized based on the data for testing, vaccines, and recovery resources, and recognition of the impact of anti-Black racism and the need for the collection of race-based data. So that's in our position statement, and we're sending that out as a resource to educate. So we're engaging in respectful and culturally appropriate information provision on facts on COVID-19. So we see our role as providing the facts, that is it. And so webinars and social media, and vaccinate. So this Saturday, we will launch our first Black community-led vaccine clinic at Taibu Community Health Center this Saturday. And so culturally safe environments for vaccination with our network of Black vaccinators. Next slide. But simply to say, this will be something that we'll be going across the province of Ontario, but we are recruiting Black and BIPOC physicians and engaging healthcare providers to be able to provide information in a culturally safe way, and also safe spaces for vaccine administration. Next slide. Now, I know that you folks wanted to know, what can you do as providers, right? So that's what the BPIO is doing. And so just to let you know, so I thought very deeply about where we know that we've experienced this kind of vaccine hesitance. And it does occur in Black communities with regards to the flu vaccine. This has been demonstrated in studies, for instance, by Jeff Kwong, who's at ICES. And at Taibu Community Health Center, we were able to increase vaccine rates from 9% to 58% over time. And it really came from, and we're diverse providers, so includes white providers. So thinking about what we could do. And so this is just a word cloud of what, when we ask patients about the flu vaccine and their hesitance around it, you see never comes up as far as their plans to get the flu vaccine. But they did, so it increased over time. Next slide. So this is the key piece. I am based on what we know that worked at Taibu with multiple different providers. My advice to you for addressing distrust, not every Black patient has distrust. So where there's distrust, please note, then we're proposing to use the LEAP discussion approach. So listen to patient concerns. And they might not explicitly mention racism, because systemic racism is just a feeling of exclusion. So it's going to be perhaps distrust of certain systems. Empower them, so reassure the patient. So don't come in with a patriarchal colonial approach of like, you must get the vaccine. Non-judgmental way, it is their choice, not coercive. Respect their self-determination, and reassure them about that, be explicit. Acknowledge the historical and present day lived experiences that have led to their distrust if they bring that up. So not trusting government or healthcare or researchers. And there might be other factors that might not be racism. People have different lived experiences, but provide facts. And that's where we see our role as Black physicians as well. Dispel myths, absolutely dispel myths. Offer resources, general and culturally relevant, depending on their choice. Some Black patients want resources that are specific to our community. Some don't. They want to be just treated like everyone else. And if they're ready, then administer the vaccine. So LEAP approach, we think, might be your best approach in having the discussion. Next slide, and I'll wrap up now. And then please, in the chat, like I said, we will come back, either myself or a member of my team. So let us know if there are other things that you would like to know about Black populations and the COVID-19 vaccine, or how it is affecting our communities. Next slide. Oh, no, that's it. Sorry. And there are resources, right? So there are resources that you'll receive on diversity resources in general around vaccine. And a lot of what I said applies to many other groups as far as a culturally appropriate approach, Black community and COVID-19 resources, including information at Taibu Community Health Center. And if you're interested in issues of race-based data collection, there's the Black Health Equity Group about how Black communities want data collected. And if it's racism in medicine in general, you can also check out my website. I've got a number of reports and research across Canada. Okay, thank you.
Thanks so much, Onye. I think that was really enlightening. And I think the LEAP framework is really practical, one that we can implement in everyday practice, and I think aligns well with the PROTECT framework that we've gone over before here. As you were discussing, I think there was a couple of people in the chat or in the Q&A who remarked, that they themselves haven't noticed as much, too much hesitancy among their Black population, but more in their, middle-aged white people who are quite hesitant about, I think, AstraZeneca in particular. I think as I was reflecting on that, I wonder if part of the issue, of course, here is also us making it accessible for people who are in Black communities. And we know that that's been a big challenge to actually have the vaccine clinics and vaccine mobile clinics, et cetera, located in communities where people live and work who don't have time. I don't know if you have any comments or thoughts on that.
Yes, so we are starting at Taipu Community Health Center, and we'll be working with a number of different mobile clinics. We also want to work with private industry so that we are giving webinars to, like factory workers or PSWs, and then, the next day we show up with the van kind of thing. So those are our plans, but it does take time, and we are under-resourced and we are underrepresented in medicine, but we are doing our best. So we hope to, receive more supports and recognition, but there certainly has been an increase, like I said, across, you see it in the US and the UK, that confidence has increased, but it's still more of a hesitancy, I think, in a number of communities. So it's both. It's accessibility, it's education, it's outreach.
Thank you. So just a reminder to put in your comments in the chat about what kind of resources would be helpful for you as you have these discussions with your Black patients. And if we do want us to have others to join our session in the future, who in particular, or what kind of perspective would be helpful to hear from. I think I'm just going to read a comment here. Thank you, Dr. Nnorom, for bringing up that we need to frame this differently. And it's not as much the hesitancy of BIPOC individuals as a concern, but the inequity and biases of the current system with an anti-Black racist bias that is allowing this to happen. I'm a physician practicing in the high-risk area of FSAs. There's limited delivery, limited access to vaccine here, and not a lack of interest. So that's from Dean Roll. And I think Darren Larson said something. Indeed, we're only seeing the Black people who want the vaccine, not the ones who don't. And so I think some great comments and discussion there.
Yeah, I think that's the selection bias for us as practitioners. We're not seeing the denominator. So you see the people who want the vaccine, but all the people who don't want the vaccine or don't even trust a non-Black provider, you're not seeing those people. So in our communities, we're having webinars where we're definitely seeing people who don't have that confidence, but we're helping with that. And then there's the accessibility issue where there's people who want it, they're scared because they're family members and they're seeing that it's significantly impacting the population and they can't get the vaccine. So there are two problems, but as providers, you're not seeing the people who don't want anything to do with providers, but we're hearing from them.
Thank you for sharing this, Onye, and for the work that you and your colleagues are doing. I'm going to shift gears now a little bit because I know there are a lot of questions in the Q&A about the vaccines, and then we're also going to hear from David Kaplan about the primary care pilots. Before we go to David, I'm going to just ask Daniel Warshafsky to speak to a couple of the questions that we're seeing in the chat, in the Q&A about the vaccines. So I think the top question right now relates to AstraZeneca because there's of course been so much in the news about it, and then the evidence is changing. Why should we recommend AstraZeneca when Pfizer Moderna is better and safer? Asked Nita Vidge. So I'll turn that to you, Daniel, to start us off, and others can chime in.
Sure, thanks, Tara. Yeah, I mean, the number one thing to remember at this point is that the vaccine that's best for you is the vaccine that's available to you right now, especially in Ontario and Canada. So not everybody is eligible for Pfizer Moderna. I agree that would be the preference if we had enough for everybody to get it immediately, but unfortunately we're not in that situation. So if you're somebody who's eligible for AstraZeneca, the protection you're getting from that vaccine is infinitely better than having no protection at all from any vaccine. And I think that's the number one thing that we need to remember, and we need to be advocating to our patients, is that protecting from a vaccine now is better than, potentially better protection 3 months from now.
Does anybody else want to add in there? Liz, sounds like you wanted to.
No, I mean, I was just going to underline what Dan said. I think that's well said. It's difficult right now, for sure, these conversations that we're having. But I think at this stage, with the variants rising and what we're seeing and the announcements that were just made recently around hospitals and closure of, certain services, given the challenges, I think it really is so essential that just patients get a vaccine and get it now. But acknowledge it's a challenge with the difference between them.
Yeah, I mean, as most of you know, I think the European Medicines Agency did release a more fulsome review and saying that the benefits outweigh the risk. I think I also wanted to share, and Brian, I don't know if you can bring up the Our World and data graph. I wanted to share, I think, what is, some real world data. We know in the UK, the vast majority of people there have received the AstraZeneca vaccine, and they've actually only received one dose of the AstraZeneca vaccine. So Brian, if you can pull up that Our World and data graph, it shows you, and I'll put the link in the chat as well. You can see here the really steep decline in COVID cases in the UK. And you'll see that about almost 50% of folks in the UK received the vaccine at this time. I believe most have received one dose, but it's been effective enough. Of course, they've also had social distancing measures and restrictions, but we now see this really steep decline. And although it's not trial evidence, it does speak to, I think, the effectiveness of the AstraZeneca vaccine in reducing cases and getting things under control. Okay, you can end slide the display now, Brian. I think this question is actually also related to the other top question that we have, this one from Abraham Friesner, and I'll turn this to you to start off with as well, Danielle. So there was a lot of discussion at our last session about this, and so he's saying at the last session, I asked if there is any evidence to show that the second dose of Pfizer gives the same protection or better when given at a 4-month separation, as opposed to the recommended and tested 21-day separation. At the last session, I was given several links, but none of these links answered the question. Could the question be answered this session? I will say that there's a question further down that I saw from Joe Smezik, which is very similar. I've reviewed the full NACI statement on the 4-month delay of dosing. I don't see any studies looking at delay of more than 80 days after initial dose of the mRNA vaccine. Is there data beyond 80 days that looks at the 3 or 4 month time frame? Has the delay been studied with the context of variants?
Yeah, thanks, Sarah. Again, this is a really great question. I mean, the first thing to say is no, we don't have a clinical trial that is looking at a 4-month interval for any of the vaccines that we have available. And like, to be fair, we will probably never have that clinical trial that's going to do that specifically. The NACI statement that was just updated yesterday goes through, again, the principles that were used in order to make this decision. So it's based on a couple things. It's based on the data we have about the efficacy of a single dose in the trials we do have, which for the different vaccines go to different times. For AstraZeneca, it goes beyond 12 weeks. For the mRNA vaccines, not quite as long. And we show that at least in that time period, the efficacy is maintained. We have some real world data from the UK, which Tara just showed a little bit of it, that demonstrates some people past 4 months in the UK and still showing overall at population level effects. Again, we don't have individual level antibody titers that are measured, and that's not something that we're going to have. The other things in the NACI statement that make it clear, this is based upon the principles of vaccine science and immunology that we know of and experience with other multi-dose vaccines. We know that the longer interval between a first dose and second dose generally provides a better response for any vaccine that we're giving. That's why if someone has a late dose, unless it's for post-exposure prophylaxis, we usually aren't too concerned if the dose comes a little bit later. We're very concerned if it comes too early, because then the immune response doesn't have the time to act appropriately. But for a late dose, it's really not a problem for other vaccines that we give. The other things that we see are for vaccines where we do have a series that goes extended past 6 months, we see the protection last 6 months or longer for the other vaccines. So while we don't have that specifically for the COVID vaccines, we have that based upon other vaccines that are out there. So I think, it's unfortunate that we don't have the direct clinical data for this very specific use. And again, unfortunately, we won't have it, but based on the principles of vaccines we do have available, the data we do have for the vaccines that are currently working. And again, remembering that we are in a shortage of vaccine and we need to protect the entire population of the country as soon as possible, that the principles laid out by NACI is really an excellent explanation for why we should be following a 4-month dose interval. And again, we do have specific exceptions for groups that are at exceptionally high risk so that those individual people are protected sooner.
And so just to run through those exceptions, do you have them on hand, Dan? Are you able to speak to them? I think It's long-term care residents, residents of retirement homes, elder care lodges, assisted living facilities, those on designated remote and isolated First Nation communities, as well as transplant recipients and individuals with malignant hematologic disorders and non-hematologic malignant solid tumors. I think, yes, including those receiving active treatment. So I'm just trying to read out there what I think the exceptions are.
Yes, and it does not include patients only receiving radiation therapy. So it's active treatment, chemotherapy, targeted immunotherapy. And I can post the guidance in the chat if Dan doesn't have access to it. I think I have it up here.
You'll be faster than me.
A reminder that we've updated our COVID-19 e-modules, and we have a whole module on emerging topics, including one on the variants, including one on this dosing interval, and including one on VIP-IT, and those are excellent sort of resources that you can go to, including, if you want an updated chart on the variants in the vaccine, which I noticed was another question. But at this time, I wanted to just turn it over to you, David Kaplan, to see if you wanted to give us a little bit of a rundown of where we're at with the primary care pilots. Sure. We heard about a couple of them last time. How did they end up going? Mm-hmm. What are the next steps?
Sure, that's great. Thank you so much. Yesterday at a call with some of the news sites, and I'll talk about that in a minute, we heard that over somewhere upwards of 99% of the initial 30,000 doses have been distributed in those 6 public health units, which is great. I think we heard wonderful stories of everything from drive-through clinics now that the weather's better, to people running, a clinic an hour or two a day in their office, to full weekend clinics. So really the breadth of family medicine and different ways of doing it, and people have been successful in doing it in all those ways. Because of the success of the pilot, the ministry, and if people recall, the initial allocation of Covishield AstraZeneca to Ontario was about 190,000 doses, of which only 30,000 went to primary care providers. For the week of April 5th, this week, an additional almost 650,000 doses came into Ontario. The government decided to distribute 20% of those doses to primary care clinics, and all 34 public health units they themselves have identified additional practices working with their health system partners. To give you a sense, that's about 116,000 doses in this allocation of AstraZeneca. The expectation is those doses will be used by the end of April. To give people a sense of the size of those doses, so whereas the initial public health units more or less only had about 4,500 doses, Toronto had 7,000. City of Ottawa is getting 11,000 doses. Toronto's getting 18,000 doses. I'm just trying to pick out some. Peel's getting 15,000 doses. Simcoe Muskoka 4,400. Thunder Bay 400. So a bit of a distribution based on population size, but also on severity of COVID burden. York Region's getting about 14,500 doses. So all in all, there's been upwards of, I believe, already 300 practices across the province that are in the process of being onboarded. I believe there's a total of 500 that have put their name forward. I know some public health units have used their epi teams to identify the practices in the most high needs areas, to go back to using an equity argument, and also used it based on the coverage from the pharmacy pilots. And I'm sure most of you saw in the news that there was a disconnect between the geography of the pharmacies that offered AstraZeneca and neighborhoods in the province that were most hit or disproportionately hit by COVID. So that equity lens using incidence and marginalization indices was used by a number of the public health units for selecting those teams. The other thing that's changed over the course of the pilot, many of you recall that it was originally for people over 65, then it went down to age over 60, and now it's anybody over the age of 55. And looking forward to hearing more about those. If anybody is on the list and knows that they've been contacted by their public health unit that they're going to start, we have established sort of a get started session and a forum online to share best practices, and I will post that in the chat shortly in case your public health unit hasn't given you those links, though most of them will be getting them today again to share with the practices that are going to be getting AstraZeneca. I think that's the update for now on that.
Thanks, David. I think there are some question I saw that somebody's had a patient who is in a hot spot, but they haven't been able to book an appointment since there's no section for that right now. My understanding, though, is that becomes live today. So if your patient maybe tried a previous day, it probably wasn't in the system, but hopefully today it will be. John Tory announced that it will be for the city clinics. And then I guess the other thing that makes it very complicated in Toronto is that there is different postal codes assigned to different hospitals, but let's see if they change that at this time.
Yeah, and I think the other thing is in a place like Toronto, aside from the public health clinics, all the hospitals run their own clinics, and those hospital clinics each have their own booking sites, and it takes time to, and we found this with the with the AstraZeneca pilot for many of the sites that were using some of these booking tools, it took some time to get the vendor to change that. So that was a bit of a problem, and even getting the COVAX on booking to change, it wasn't so easy to add things like filtering by FSA and stuff. So I'm sure there'll be some glitches. Yes, you need a PhD, as Kavita says, to figure it out. Not good, not great.
There are some, really resourceful family doctors who put some stuff together, and so we'll see if we can assemble that and send it out to everybody, because I know some people have put together their own lists to guide patients, which we shouldn't have to do, but is happening.
And I see Liz's comments in the chat, and I agree. The public health units, if you have not been contacted and you want to take part, please contact your local medical officer of health. They'll connect you with the person within the public health unit. We've had a couple more practices. It's taken some time to get them to agree, but we've added them this week, especially in areas that really need the vaccine coverage. So absolutely.
Okay. So I'm going to switch gears a little bit, and then we'll come back to some more of your vaccine questions. But I'm going to switch gears, and David, I'm going to go back to you to talk a little bit about what's happening right now as a result of rising COVID numbers. I think those of us who were listening to the news this morning probably heard about the direction to Ontario hospitals that are, all hospitals except for the north, that they now need to defer all non-emergent surgeries to create room in their hospitals and in their ICUs for COVID patients. So that's, a real sobering announcement. And how does it, what does it mean for us as family doctors as we see these cases surge?
Absolutely. Thank you so much. Not something that I was planning to talk about this morning, but thank you for giving us the space to chat about it. So as many of you probably realize, the rate at this point in Ontario for increase in COVID cases in wave 3 is faster than at any point in wave 2. As of this morning, there's 541 patients in our ICUs in Ontario with COVID-related illness, with a total ICU census of like 1,869 patients with COVID. There were 54 new admissions yesterday, and really by the end of the week, or by the end of the weekend, we will probably be at our ICU capacity. Canada, by the next couple of days is likely to exceed the US COVID infection rate within days in cases per million. And because of that, and the need to, look after patients, there's been two things that have happened. The first, as many of you know, is that we set up a regional IMS structure where we've, with the consent of patients, moved patients between hospitals. So if you were admitted to Mackenzie Health and there were too many COVID positive patients and Mackenzie Health needed to make capacity, those patients were moved to a different hospital. That's pretty much unprecedented in probably Ontario's history. But we've needed to do something different, and because of what's going on in the ground and in the field. And so late last night, Matt Anderson, the CEO of Ontario Health, instructed all hospital CEOs that as of Monday morning, hospitals are to ramp down all scheduled surgeries, so that's elective surgeries, and all non-emergent and non-urgent activities in order to preserve critical care and human resource capacity. So that means that life and limb surgeries only. The letter also is directed at primary care providers, and I've asked the OMA and the primary care organizations late last evening to ensure that each of you get a copy of that letter through your associations, as the government doesn't have a way of getting it. We don't at Ontario Health at least have a way of getting that out to everybody. We've also asked going forward that available healthcare workers and teams in other areas of the system or parts of the province may be moved around or be asked to be moved around, and staff could be deployed to other sites requiring support. And then for those of you who are working in the hardest hit hospitals, to really help integrate these staff members into your teams. And then lastly, and this is, I want to focus on, we've asked that all primary care providers continue to maintain our important role in maintaining care for everybody in the province. We know that our patients need continued access to essential primary care services, and I say essential because we're going to ask people to focus on two other things in the next 28 days. So essential primary care services, and that includes cancer screening and immunizations. So cancer screening and immunizations should not be deferred. In addition, and this is where the pivot is to your continued COVID-19 response efforts. And we know family doctors and nurse practitioners and others have been so key in mounting our system response to COVID-19 in our assessment centers and our vaccine efforts in mobile and long-term care and in your offices. But we are asking, as of late last night, that everybody focus on vaccinations, their human resources on vaccinations, and additionally on COVID at home. COVID at home is a program by which people with mild symptoms can be monitored, who are positive, who may be at higher risk for developing bad disease. And the idea is that you can monitor these people at home with a pulse oximeter so that they can be picked up early if they're having desaturations and not symptoms, so that they don't end up crashing at home. I actually know of this week of two patients, both of which have died at home because they weren't being monitored close enough. And these weren't people with severe disease at presentation. The other group in COVID at home are patients that could be discharged from hospital early in order to make additional bed spacing. And so in an ability to decrease length of stay, we are recommending that patients have some of their oxygen titration. These are patients who are often have been in hospital for quite some time, and they still require oxygen titration or weaning, I should say. And there are protocols for doing that in the community and working with respiratory technicians. and oxygen service providers. One of the clinical leads for the COVID at Home program, who many of you may know out of Hamilton, is Dr. Dee Mangan, and she gave a talk about COVID at Home at the Family Medicine Summit. The OCFP is kindly making it available for free with MainPro credits, and Mina will be posting that in the chat. Additionally, we'll be hosting some webinars early next week for people who want to find out more about providing COVID at Home services. And that as of late last night, I was on the phone with senior ministry officials who will today be directing all primary care-based teams to support COVID at Home. And that will be a very specific direction to the almost 400 primary care-based teams. For people who are not part of a team-based model and you want to do this, not just for your patients, but for patients in your community, I ask that you reach out to your CHCs, to your family health teams, to your NPLCs, to your Aboriginal health centers. We'll be posting the links to find those closest team-based models in the chat. We definitely need everybody to pivot to looking at, to doing the two most probably important things outside of providing urgent primary care to your patients, and that's being involved to get adults in this province vaccinated over the next 28 days, and then looking for COVID, after COVID patients who can be safely monitored at home. Thanks, Tara.
Thanks so much, David. So just a few really good resources being posted in the chat. I think Terry Weinberg put a link to being able to find some vaccines if you're in the GTA area more easily. Mina's put in the link for the OCFP Summit recording of Dee Mangan giving her COVID care at home talk. And we did have Dr. Payal Agrawal on our community of practice on November 13th. And so you can go to our past sessions, which I've also put in the chat. And I've also connected to the Women's College Hospital COVID care at home site there. Interesting comment from Darren Larson, who said, scary and interesting on the ground stat. The average age of my COVID care clinic last week was 29. So yeah, it's scary and interesting fact. So, you know, I want to go back to a few more.
There was a question, I guess, about the SAT monitors.
Oh yeah,
yes,
go ahead.
Yeah, so the ministry has already procured about 10,000 SAT monitors, with more on the way. About 3,000 of them have already been ordered. There is, I'm going to be posting some more information about COVID at Home in the website links. I just couldn't do it while I was talking, but thanks for asking. There's also a link on how to order those SAT monitors. So if you are a practice that wants to order those today so that you have them on hand for next week, absolutely go ahead and do that. And I'll post those links in the chat. Thank you, everybody, for asking.
So I'm just going to go to a few more questions that we have about the vaccines, and thanks to our panelists to continue to answer them in the Q&A. Dr. Sung is asking, is the change in time interval from exposure to testing from 5 days to 7 days due to the increasing prevalence of the variant? And I'm wondering, I don't know if Dan or someone else could answer that.
Yep, thanks, Tara. I can take that one. Yeah, so the update, it is because of variants. It's not because of the incubation period of variants. It's because we want to be really, really sure that people aren't actually having asymptomatic infection because of how quickly they spread. So the recommendation now is that if you had a known exposure, like a very clear discrete exposure, it was X date, that you wait 7 days, because that after 7 days, we're very likely to see you positive if you're going to become positive. Before that time period, if you do get a test sooner, we just ask that you get another test sometime after 10 days, again, to just confirm, because of we really don't want to be missing variants that are going out. That's the reasoning behind it.
Thank you. I noticed that you also did answer another popular question about mixing vaccines. It sounds like, Dan, what you said was that there are trials currently underway in the UK, US, and Canada. But at this time, we don't have data on mixing vaccines, but hopefully are expecting results from trials in May. And it's likely that mixing doses will be an option and even recommended if the first dose was with a less efficacious vaccine. So stay tuned for more information on that in May. So I'm going to go back to you, Dan. Hal Braden has asked, what's up with AstraZeneca and most recently, as of this morning, J&J? Apparently, North Carolina paused its use due to adverse effects. So I haven't actually heard this yet, but maybe you have.
Yeah, I haven't gotten any information on Johnson & Johnson yet, so I'm actually not sure what the reason behind that one is. We're still waiting to hear more. For AstraZeneca, I mean, the European Medical Agency, I think it was 2 days ago now, put out their update saying that they're no longer restricting use of AstraZeneca. So not every single European country has followed suit, but the EMA recommendation is to use it broadly in the population at any age, with, again, acknowledgement that this vaccine-induced prothrombotic immune thrombocytopenia is a rare complication that can occur. The numbers we've seen are still in that same range. Again, since it's quite rare, we still have a few numbers overall. So it's somewhere between 1 in 100,000 to 1 in a million people that will get it. But it's something that should be acknowledged as a risk for sure. But again, considering if a person should have protection from a vaccine now, considering their other, the chances of them catching COVID, which would certainly lead to almost certainly worse results than that, then it's a consideration so that people are counseled appropriately to get that vaccine. NACI hasn't yet updated the NACI statement to go in that direction, but I understand that they're deliberating based on the EMA's update this week, and so we do expect that to be in the next NACI update next week.
Colleen Chung has said, can you please comment on COVID infection after COVID vaccination? What is this about? Is it variant breakthrough, poor immune response?
Sure. I mean, as always, none of the vaccines are 100% at 1 dose or 2 doses or any situation. So we know people are going to get COVID infection. The rates of infection that we're seeing right now in Ontario are basically consistent with the vaccine efficacy that we're seeing. So we're not seeing incredibly high levels of vaccine escape. In terms of the vaccines that we have now in use, they're all very effective against the B117 UK, which is now the predominant strain in Ontario. We still have relatively few cases that are a different variant, so that are E484 positive on the screen, just under 10% in Ontario at this point, but we aren't seeing higher levels of vaccine escape. So for the individual person, it's hard to say for sure why that individual person missed it. They probably were one of that percentage of people that didn't get the response from 1 or 2 doses, because we're certainly seeing cases in people who have had 2 doses as well. But it's expected just based on the numbers that we see.
And so then the flip side of that is someone has had COVID, and what guidance do we have around vaccination after getting COVID? So Marcy Greenwald has asked, can you please discuss vaccination post-COVID? Apart from the recommendation to get 1 set of isolation and feeling well, is there any evidence of delaying it a few months due to presumed immunity post-infection? And I think Regina Agbayani asked similarly, can we give someone the vaccine post-COVID? Which the answer is yes, we can, but I guess the question is when.
Yeah, exactly. So we're still, as was noted, and sorry, but I'll repeat it anyways, we are still suggesting that you give it as soon as possible after someone is no longer infectious. We do have studies looking within the shorter intervals. So we know that COVID infection leads to natural immunity roughly lasting about 3 months for most people. We do have studies looking at the vaccine giving that time period, and shows essentially the same level of efficacy. Earlier on, there were concerns that, by having the antibodies to the natural COVID infection, would you get poor immune response from the vaccine? But that is not something that we've demonstrated. It's basically like an additional booster on top of your other booster, right? If we think of it the way we'd be giving a vaccine. So the reasoning to wait the 3 months would be because we have a shortage of vaccines, and we're doing a population level vaccine program. And so getting more people the vaccine sooner is a benefit if we can. But at this point, the number of people that are in that window, it's just easier to get people the vaccine as soon as possible if they're in a priority group, and not be trying to work around the complexities of, exactly when was your COVID infection.
Great. So I'm just putting up a slide here to remind people of our free COVID-19 vaccination modules, and you can access them at that link, and we'll send that out in the with the resources after the session. David Kaplan has put a ton of resources in the chat, and we'll be collating those for everyone. so that you have them on hand, along with Onye Nnorom's resources, as well as perhaps some. We've seen some, requests for things like more information on the variants, and we'll do our best to gather those as well. You may want to check out our past community practice session on February 19th, which was on long COVID, which has become more and more relevant. I think Jordana Sachs, you're asking about the vaccine and the variants. So again, I'll ask you to just check out our module on emerging topics, and we have one specifically on the variants and the vaccine. So thank you everyone for joining our session today. Next slide, Brian. We are running these sessions now every 2 weeks, and we welcome your suggestions for topics for our next session. So you can send them in our evaluation. We really look through all of your evaluation comments, so appreciate you filling those out. If you want to go back and review today's session or forward it to a colleague, it will be available early next week. And as mentioned, all our past sessions, all our past sessions are available for Main Pro credits, and some of them are particularly relevant now, including that one in November on COVID care at home and February 19th on long COVID. So thank you again for joining us. It is a scary time and a sad time, but also one, we've got to look, I think, to the light of the vaccines. We have now a stay-at-home order in place. We're hopefully going to get the numbers under control. And as we do that, our job as family doctors is to help as much as possible with the vaccination and to care for our patients who are getting sick. And so with that, thank you so much for all of that you do, and we look forward to seeing you back here in 2 weeks.